working on my slides here. So now we get to move into how the TAF data have come to be released to researchers. Now that we have an understanding of Medicaid programs and who they're serving. We'll just give kind of an overview of why and how the claims are submitted, and then how they're released to researchers. And this is our schema for the day, or for the segment. It's kind of how the data moves from states into an interim kind of file, and then finally a RIF, research identifiable file, which is released to researchers. So when we think about the state Medicaid agencies, we've kind of talked about how they can either administer a Medicaid program themselves, where they are paying, they process the fee-for-service claims, they pay the providers, or they can also contract with the managed care organization that will process the claims and pay the providers on the Medicaid program's behalf. And we've talked a little bit about the fact that there's a lot of use of managed care. And one of the interesting things about managed care in Medicaid is that it's not everyone is comprehensively covered by managed care. They might be in a managed care program that's specific to their behavioral health needs, and then have a different program for a dental need. And so we'll talk a little bit about how that might show up in the files as we go through. The agencies, we also talked a little bit about how these are, this is a state and federal partnership. So there are matching dollars associated with the money that goes out to providers to pay for Medicaid costs. When Medicaid agencies are reporting their financial information, they use something called Form CMS 64, and they submit enrollment, eligibility, and financial information through that system. When they're submitting these claims, and these claims and also enrollment information and eligibility information through this T-MSIS program, this is really for program oversight. So it's not exactly like CMS is paying on a per claim basis for these. So it's a little bit different than we would think of for fee-for-service Medicare, for example. So let's start at the state level. The states have made their data into a T-MSIS format. These files are going to be submitted monthly to CMS, and they cover everything from utilization, enrollment, and eligibility, all of the claim adjudication, and including children's health insurance program information. This wasn't necessarily the case before T-MSIS. Sometimes there were CHIP programs that were combined with Medicaid programs that might have submitted claims, but with T-MSIS, we now have all CHIP information. Also, there's managed care utilization information. I know there have been some questions about that. The utilization gets sent from the managed care organization to the state Medicaid program and then passed on. And then I'm thankful for all of the resources that have been shared. This is one of those pieces that is tricky with Medicaid data, how complete this information is. We have the same issue with the Medicare Encounter data. People want to know, that they're getting everything, and sometimes it's difficult. And I think that as researchers use it more and share information, it's just going to become more and more clear over time. There's also information about provider participation, so who is seeing Medicaid patients, and then financial transactions apart from the utilization payments to providers. So if there are policy payments like disproportionate share hospital payments or managed care capitation payments, that information also gets sent through the T-MSIS system. T-MSIS is relatively recent. It goes back about 10 years to 2011. One state had transitioned their system over to T-MSIS, but all states weren't complete until 2015, as we sort of talked about earlier. So this was a heavy lift for a lot of states. They had to make sure that they could, when they moved from the Medicaid Statistical Information System to the T-MSIS, there was a lot more information that was collected, and there was a real attempt to increase the standardization of data elements. And this required states to do a lot of work to try to get their systems to work with T-MSIS. And you'll see that that the data quality, we'll talk a little bit about it later, but it's always improving as states do more and more work. And T-MSIS has or I should say this, the CMS has made a real concerted effort to give states feedback on their quality and on the quality of their data that they're submitting, so that they're able to keep improving. From T-MSIS, a file that is created is called an Interim TAFT that's created at CMS. And this file, it's important to understand this Interim TAFT because some of the resources that you'll find online apply to the Interim TAFT. So Interim TAFT is not exactly what's released to researchers, but it's a way of taking all of the 50 states T-MSIS data and putting it into one file. So when T-MSIS, the T-MSIS data from the state TAF interim data, there are some updates. So enrollment and eligibility information is enhanced. Because there's lots of information being sent all the time, there's an effort to select the most recently submitted information. So you'll see some information on the TAF is monthly, but sometimes you'll see things that are, at the end of the year, or if for example, when a state submits information for one person, they may have missed the birth date, but with TAF, they're able to go back and find a previous record for that person that has a birth date. So it's called last best. The last best information will be used in order to populate the data. During the transition from T-MSIS to TAF, there's also an effort to reconcile conflicting information, recode any out of range variables or invalid variables, and then combine the monthly submissions over a year in order to track enrollment. So then you're able to see, for each month of a year, what was the enrollment like. And then there are some variables that are added at the year end. So if a criteria was met at any point in the year, you can see that's the case. You might want to select on those variables as a kind of a shortcut rather than trying to move through all of the information in a year. And then there's also some claims file enhancements. So monthly files are created based on dates of service. So you remember states are submitting monthly based on the adjudication date. And then when TAF is created, it's now reorganizing that to be based on dates of service. And we have final action claims only. We'll talk a little bit more about that later. So final action claims would be after a claim has been worked on. It's been come back and forth between a provider and whoever's paying it. Maybe there was some discussion about the proper payment. At the end of all of that, it's the final action claim. We also don't see in the TAF fully denied and voided claims. We're going to talk a little bit about that later. Denied lines are included. So for example, if a claim is submitted for multiple services and only one of the services is denied, you'll see that claim. But if the full claim was denied, then that does not get included. And then there is some recoding that's done for information that's valid or out of range. There's not recoding done for diagnosis and procedure codes or things like that. And then finally, we get to the files that are released to researchers. We call them the TAF RIF files. And when you look at the CCW data documentation for TAF, that's going to be primarily talking about the TAF RIF data. If you look at some other information from maybe Medicaid.gov that's talking about TAF data, it may be instead referring to the interim TAF data. So you just, if you see something that doesn't jive with what you have in your data, that might be one of the reasons. So when we look at Medicaid RIF formats over time, there was a max file format for many years, and the source files for there were quarterly MSIS files that were submitted by the states. Then the max T file came along because some states had mid-year transition. So this would be fit into the max file format, but then the source files would be the T-MSIS monthly files. And then finally, states have now moved all over into TAF, and this will be our CCW TAF file format. And we get the source files for those are the TAF interim monthly files. We will have mostly you'll be requesting on an annual basis, but when the TAF data are created, they're created on a monthly basis. So what does that look like? I mentioned that some states took longer than others in order to transition over to the T-MSIS system. So this, we can always check on our website for the most recent version of this, although everybody in 2016 was moved over. So you can see that, for example, Arizona transitioned in October of 2014. And so the file for that year is a max T file. So it's max format, but TMSIS data, some TMSIS data was used to populate that format. And then starting in 2015, because they had all TMSIS data, then they could move to a full TAF format. Arkansas, we had no Medicaid source data for 2016. It wasn't submitted, so we just don't have that for that year. But that's something that's always being improved upon as well. So when we look at the CCW TAF RIF production, what's the difference between the interim and the TAF RIF? There are things that have been changed. So from TAF to TAF RIF, service tracking claims were pulled out initially. You now have an option to say whether you want them. Service tracking claims are going to be claims that are not tied to a person. They're instead usually lump sum payments that the Medicaid program is providing. You know, it might be to a managed care organization. It might be to might be a retainer for home health or things like that. So those are available now, but originally they were excluded completely from the data, and now it's an option. They also excluded records missing claim type code. We'll talk a little bit about claim type code. That tells us how the claim was paid. Was it paid by a managed care organization or by a state Medicaid program? Anything that was missing the MSIS ID, or if the MSIS ID was unusable so that CCW could not assign a person to the claim, that is removed. All personally identifiable information is removed. And then CCW Benny ID is assigned. And we'll talk about that. So if you've used other data sources, the CCW Benny ID is a way of tracking a beneficiary across different programs. You don't, there are some files where we're going to, there's other than the CCW Benny ID. We'll talk about that in a minute. Also, there are some data elements that were renamed in order to have consistency with other sets. Something that we'll talk, I have a slide on later, but just to reiterate, because there have been questions. Charge and payment amounts are removed from encounter records or managed care records. So those are redacted, they're considered proprietary. So that's one, when you get the TAF RIF data, you will not find those amounts. And then anything that's unreliable was also removed, and you can find information about how these data were created at medicaid.gov, excuse me. And if you want clickable links, the printable file doesn't have them, but if you look at the non-printable slides, you can click on these links. So there are 7 different file types within the TAF RIF data. There's an annual demographic and eligibility file, which is actually a suite of files. Almost all of these file types will have more than one file associated with them, which we're going to go into detail on. But so we have, the annual demographic and eligibility is really our enrollment file, our denominator. The inpatient, it's all inpatient. Long-term care, you can imagine what that is. It's any long-term care. We have a pharmacy file, which is RX. And then we have an other services file, which is abbreviated OT. The abbreviation is correct, but it's kind of a carryover. It used to be other therapies when it was in the max data. So we have just an OT file that's kind of everything else that doesn't fit into those other categories. In addition, just recently, a TAF annual managed care plan file has been created, and then a TAF annual provider file. So these are both only annual files, but they have some information that you might find helpful to merge with your other TAF data. So as I mentioned before, the TAF are organized either by date of enrollment or the date of service. So the way that the files are created are going to be based, if you're getting a 2018 file, you're going to have dates of service in 2018. You're going to have dates of enrollment in 2018. Any invalid or out of range values are transformed into null. And then when you look at the TAF data, we do have Medicaid and all CHIP, whereas Max was limited to MCHIP, as I mentioned. Oops. So I mentioned before the CCW Benny ID on the files. I think it's just called Benny ID. This is assigned by CCW, and I think I'm realizing that we've never explained who CCW is. It's the Chronic Conditions Warehouse, and it's another CMS contract that creates the files that researchers access and also can house the data and deliver the data. So if you're accessing the data through the virtual research data center, then you will be accessing it through CCW. If you're getting files delivered to you, CCW is sending them. ResDAC doesn't send the data, we just help people request it. When the Benny ID is created by CCW, it's one that's assigned per person and it remains constant over time. The MSIS ID is the other main identifier that you'll find on the TAF files, and that is assigned by states. One person might have multiple MSIS IDs across states. You can imagine if they move and they're enrolled in 2 different Medicaid programs, the states don't share the MSIS IDs with each other. But sometimes it can even happen that they have a different MSIS ID within the same state. So that will impact how we create some of our analytic files as we move forward. So let's talk about the first file that you could look at. We have an annual demographic and eligibility file, often called the DE file. These are the eligibility records. So how did this person become enrolled in Medicaid? It's a monthly beneficiary summary file from T-MSIS, and then when you get the annual DE file, that comes from that beneficiary summary file. The annual DE has 1 record per person eligible or receiving a paid service in the calendar year. And there are 7 segments to the TAF DE. And in order to move across these segments, you're going to want to link by MSIS ID and state code. Benny ID won't be sufficient because if someone has 2 different eligibility periods, maybe they're eligible under one condition in one period and then they become eligible under a different condition. When you're linking across the DE files, you want to make sure you have the correct information linked from each file. So the base segment is going to have a lot of information about, and I think actually my next slide might talk about this. The DE file, the base segment has, who is this person, what is their age, eligibility, all of that. The supplementary files then will have more detailed information about dates and waiver program enrollment, state plan options, managed care enrollment, money follows the person program, and it can kind of give you information about whether that's being paid to long-term care institution or a family. And then there's a disability and need file. So the base segment gives you all of kind of your enrollment indicators, and these are populated on a monthly basis. So you'll have a CHIP indicator from January and a CHIP indicator from July and all of the months. And information on dual eligibility and whether the benefit is restricted for any reason. So every person that's in the Medicaid program has access to all the same benefits as everybody else. It depends on their eligibility, why they are qualifying for Medicaid. The base segment also has information about demographics. It has a date of death or a death indicator. This is reported by the state. So just know that it's not something that is being compared to other sources. So just that's one caveat with the date of death. The Medicaid managed care plan information. So this is a monthly yes or no enrolled in a managed care plan. That can give you an indicator of whether you're going to want to link to the managed care plan supplemental file. You can get enrollment days in each of the 12 months. And then eligibility group monthly indicators, which are state specific. So when you're trying to go across states, you might need to look closely at those. Not every state uses every eligibility group. So you'll want to make sure that you're aligning everything up. And then flags if there's a supplemental segment record also. So those would be good indicators to you that you might find more information. The dates file has information on the enrollment type and then the enrollment start date and the enrollment end date. So you can imagine that someone who was enrolled and then became disenrolled and then enrolled again would have two different records within the dates file. So you can, on the base file, you have information about the days enrolled in the month, but if you want specific dates, then you can use the dates file. The managed care enrollment file has a lot of detail. I think you can have up to 16 managed care plan types. One individual could be enrolled in 16 different managed care plan types. I don't know how often that happens, but so the types of care are kind of listed here, the care plan types. There could be a primary care case management managed care plan, or a prepaid inpatient or long-term care inpatient or ambulatory care plan. So very specific to the service type, or mental health substance use transportation plans. PACE, I should have spelled out here, it's the program of all-inclusive care for the elderly. Pharmacy plans. So it is possible for a person to be enrolled in more than one plan. Not every plan is comprehensive. So if they're not enrolled in the comprehensive plan, you might have the Medicaid program paying on a fee-for-service basis for some services and not others. The waiver program enrollment file, the waiver, this gives the waiver type codes and waiver IDs. I know that Nate talked a little bit about the waiver system in Medicaid. You can have monthly indicators for the section 1115A waiver type, or you could get summary variables for the number of waiver months for each of these waiver types as well. And you also have a latest in year. So at any point, or when during the year, the latest waiver type that they were enrolled in during the year, I guess is the best way of saying that. So that might be helpful, just if you don't want to look across months, you're just interested in kind of the latest. There's a money follows the person file, and this gives a monthly indicator of participation in this program. And like I said, you can see whether the qualifying, if it's a qualifying institution or a resident, where the person is. And then a health, home, and state plan options file. These will give you monthly indicators of health home enrollment. So if there's a chronic condition that qualifies someone for a health home program, you can get asthma, diabetes, heart disease, type chronic condition health home programs. There's also monthly indicators for state plan options like home and community-based services. So those are more files that you can link to the DE file by MSIS ID and state in order to find out more information about each enrollment period that a person was enrolled. And finally, the disability and need file. This will give one record for each beneficiary who might be eligible for long-term services and supports, or they were qualified on the basis of conception to birth eligibility. Again, you have monthly indicators, and there are disabling condition indicators like difficulty walking, difficulty dressing or bathing, difficulty concentrating. Sometimes you get excited and you're like, oh, administrative data has this type of information, but of course this is only if this is their basis for eligibility. There are also the home and community-based services chronic conditions indicators are located on this file. So there's 220 variables on this file. It's quite long, but you only have one record for beneficiary, or I should say one record for each MSIS ID and state code combination. So if one beneficiary had more than one MSIS ID during the year, then they would have two records. So that is our enrollment information. And now we can move on to our TAF claims files. So for our claims files, I mentioned before, we have inpatient files, which are all hospital inpatient claims. We have long-term care, which would be non-acute institutional claim, facility claims, other, which is kind of everything other than inpatient long-term care and pharmacy. And it does include dental services. So you will find that the dental service claim form also, will move into the OT file. And then we have a pharmacy services file. These would be services provided by an outpatient pharmacy. So you don't necessarily get to see any prescription or any drugs that are administered in a hospital, but you would find them in if they were provided by an outpatient pharmacy. And then if we're going to link the DE and claims files, I had mentioned before that you would worry that you're not getting the correct enrollment information if you're trying to use the BeneID, because you might have a many-to-many join if you're trying to link the DE to the DE base to the DE supplemental. When you're looking at claims files, if you really truly want everything that's associated with one person, one beneficiary, you can use the BeneID, and that should capture utilization across all of their enrollment periods, even if they have different MSIS ID and state code combinations. If the BeneID is missing, however, if that was unable to be assigned, then you would have to use the MSIS ID and state code. If you are really concerned about, maybe they have a restricted eligibility at one point, so you're trying to restrict to a particular benefit period, then you would probably want to use MSIS ID and state code in order to link between the enrollment and the claims files. The TAF file claim structure, this is going to be different than MAX if any of you are MAX users. There are at least three claim types three files that will be delivered for inpatient, long-term care file, and the other services file. These will be called the base claim file or the header file, the occurrence code file, and the line file. Now, to link like a header file or a base claim file to the corresponding line file, you would use the claim ID. So what do we find in each of these types of files? A base claim file will have kind of an overview of the claim. So you'll have the, who the claim is for, who the claim is paying. So who's the provider or the facility that's being paid, what type of what services are being paid. Somewhat, you'll have information on like diagnoses. The type of service code has moved. If you have been using MAX data, the type of service is now on the line file. So it's possible that you could have more than one type of service per claim. I think that, with the OT file in MAX, you would sometimes use the type of service file to say, this is a service that I'm interested in. Just note that you're going to have to use the line file now in order to determine which lines you're interested in. The occurrence code file will, not every single claim will have an occurrence code record. That will give more information about how the state is paying the claim. So sometimes if the claim were associated with an accident where really a health insurer should be involved, or maybe like an auto insurer should be involved, you can get sometimes information there. If you don't need a lot of detail about how or why a particular claim is paid the way it is, the occurrence code file might not be useful to you. And then the line file, like I said, it will be, you could have multiple services per claim, and the line file will include one line for each of those services, with a procedure code associated with, if there's a procedure associated with the service, so that you're able to account for what this claim is for. The RX file has a base claim file and a line file. And just note that not all RX claim files have a matching line file. So in general, you're going to get a lot of information from the claim file. The line file would be broken out into specific lines if there are like a compounded drug that you need to be interested in. So more detail about what we see in the inpatient file. The types of services we see are inpatient facility claims, and you might see other services if they are provided in a hospital. So it could be skilled or non-acute care if the residence is a hospital. And the claim level, you'll have maybe some stays that will span more than one claim. This is different than MACs, where we had kind of inpatient stays that were grouped as stays. You'll want to pay attention to dates of service, and you may need to combine them. This is similar to like a Medicare inpatient file. And you'll have diagnosis and procedure information, both ICD-9, ICD-10, state specific as well. For the long-term care files, this will be nursing facility services, long-term mental health institutions, intermediate care, and inpatient psychiatric stays for individuals under 21. This is again claim level, so state, and because this is long-term, many stays may span more than one claim. Service dates might be tricky with the long-term care file. So you'll have to, for example, even if someone has multiple dates that seem to line up very well, it may appear like they're discharged and readmitted at the end of each month, for example. So you'll just have to kind of pay attention to, if you're trying to calculate length of stay, it's not quite as straightforward as taking discharge or admission subtracted from the discharge date. You'll also get diagnosis information on the long-term care files. The other services file is really everything that doesn't fit somewhere else. Outpatient facility claims, professional services, dental, home and community-based services. Sometimes not every variable applies to each type of service. So that if you're seeing things that don't seem to make sense, that could be why. Like, why is this information always missing? It may just be that variable doesn't really apply to that type of service. This is again at the claim level. At the claim level, most services will be completed on one claim. So you can link to the line file to see multiple services, but generally you don't see a service that's going to span multiple claims. And again, we have our diagnosis and procedure information. On our RX files, these will be our prescription drug files provided by outpatient pharmacy. We have prescription drug fills. It generally doesn't include drugs provided during a hospitalization. And these are reported by NDC code. There's no other drug information present on the file. So if you were hoping to look at the generic name and find drugs in that way, you're going to need to link it to other resources in order to get that information. And state Medicaid program websites often will have lists of drugs covered, so you might be able to get information there. But there are also standardized databases that can be used to link to the file. One of these new files that I was mentioning, the TAF Annual Managed Care Plan file, it's a reference file, so we have this at the Managed Care Plan level, and you can link to the other files using the Managed Care Plan ID. This will give you a lot of information about every managed care plan that's authorized to enroll Medicaid or CHIP beneficiaries. So it gives you the name, the type, any waivers that's associated with the eligible population, is this CHIP coverage, and the plan service locations. There's also a provider reference file. And again, this is every provider that is associated with the Medicaid program. This will include active providers, pending, anybody that's been denied or terminated. So you don't have to have been billed for services during the year to be included in the provider file, because this is really a list of the Medicaid programs saying this file is, or this provider is associated with the Medicaid program. You do get information, provider taxonomy codes. So is this an eye or vision provider, behavioral health. You also get whether this is a residential treatment facility or a substance use disorder provider, substance use disorder service provider. You get information about the provider location and whether they're affiliated with the group practice. And this comes in multiple files. So again, we have kind of this base and supplemental file structure where there's one file that's reporting the taxonomy codes, another file that's reporting location or affiliated groups, different file that's reporting bed type. In order to link for these files to link a provider to some of these the supplemental information about the provider, you would use the CCW APR link key to link the base record. And if you're trying to link the provider to the utilization files, it might depend on which file you're using, which variable you'll use. So we can point you to some more information about that. So when the TAF are created, as I mentioned before, there's processing that's done. So these are going to be final action. We're going to not see any fully denied claims. If a claim does not fit the final action algorithm, so it can't be correctly applied to a claim set, the claim is dropped. And they're also dropped if there are duplicate header records or no header record. There's a line record, but no header record, so the claim then is completely dropped. You can look at the TAF file processing document that I linked before to get more information about that. One exception, because this is the Medicaid TAF data or Medicaid data, with so many different programs, we do have exceptions often. So Illinois actually processes incremental claims, and so all transactions will be included in the RIF. The incremental claims meaning that there's not a wait for the whole claim to be finalized and submitted. So there's still final action, they're just more incremental. And so you may have to do some rolling up of the claims. You may end up seeing something that ended up being denied as well. And there's a minimum 12-month runoff when the TAF are created. So so with the max, it was 3 quarters. So 9 months, but now we have a minimum of a 12-month runoff. When we look at managed care utilization in the claims data, we do have claim type code values of 3, C, or W that will be on the utilization claims header files that will tell you that a managed care organization is paying this claim. The header, both on the header and line files, any billed amount or allowed amount, paid amounts, copay deductible, long-term care amounts are all redacted on the files. So they're considered proprietary and confidential. They won't be reported. Any other payment fields, they would be considered that are not managed care and not redacted. So like something like a third-party liability or a Medicare payment if that happens to be available. So just to review, when we're talking about all of the pieces of these claims, some basic principles of administrative claims data analysis. One principle is that it's really important to understand how the service that you're interested in is paid. That will help direct you to look for certain things in the claims that tell you, oh yeah, this is for the service that I'm interested in. So it sounds kind of simple, but it's not always clear. For state Medicaid programs, for example, they may have different requirements for billing a particular type of service. So first you would want to know what kind of provider typically bills for the procedure of interest. So, you know, is it always done on an inpatient basis? Well, then I'm going to be looking at an inpatient file. Also, do they bill using ICD procedure codes, CPT codes, NDC codes? This can vary by provider type, and it can also vary by program. The program might direct providers how to bill, and it might be different. If all hope is not lost, you can do the best you can and, you know, try to identify things in multiple different ways. Administrative claims data analysis does call for creativity sometimes, and I always say that it's really good to work with clinicians who are billing, because then you can get some good information about how it might show up as well. Another principle is that you will likely need multiple files to observe a full scope of care. So maybe you're interested in births, and so you think an inpatient file would be really sufficient for your needs. Likely you're going to want some information about the eligibility of the enrollee, and demographic characteristics. You're also going to want an OT file in order to get any information about physicians, because in general, the physician will bill separately from the hospital in order to be paid for their time in delivering services in a hospital as well. And then, this is a record of care received. It's not, administrative claims are not designed for research. So unfortunately, when we're doing our epidemiological studies, someone doesn't just, put in a claim to let us know that a person has a condition. Generally, there has to be some care that's been received. And, if a condition is truly present but is undiagnosed, or the person never came to visit a clinician, then we don't get to see that information. And then also it has to be paid by the Medicaid program. So if the beneficiary is not enrolled in Medicaid in a particular month, you're not going to find services for them. They may be getting treated somewhere else, but it's a black box for us because all we see is what has been paid through the Medicaid program. And then also this is a record of care received and not necessarily care needed. One thing that we have trouble with is the disease recurrence. Like if you're working in the cancer space, you will only see a recurrence that's treated generally. Like I said, someone's not, there really aren't usually separate codes for a breast cancer recurrence, for example. So you might see a surgery that happens as a result of a recurrence, but you wouldn't necessarily just see an indicator that a recurrence has happened. And also, you only see the recurrence at the time the person seeks care, so you don't necessarily know at what exact point cancer started to recur. And lack of access and high volume of treatment are both sources of error. So, you might have someone that's not attending a physician, so you don't get to see the bill. On the other hand, you may end up seeing lots of treatment that perhaps was not needed. So you may, both sides of the equation can result in some bias. Additional complexities when you're trying to look at national Medicaid data, there is state variation that we're going to talk about in just a little bit here. So the programs differ in terms of eligibility, whether or not coverage has been expanded, the use of managed care and waivers. There's also state variation in the data reporting and quality. And Medicaid, even within one state, is not a monolithic program. Different groups may have different benefits. Some groups may qualify for full benefits, some partial benefits, and only the benefits that are being covered are going to show up in our Medicaid data. So I think we've left some time for questions. And I think it looks like the chat box has been active.
Quite a few. I've been kind of filtering through them stuff. So maybe the first one I think we could maybe cover is, how does T-MSIS differ from MMIS, which is the Medicaid Management Information System?
Aha. So I believe that, let's see, I hope I'm not making people sick. Oh, it's slightly different. I don't have a really good answer on that because I'm mostly on the claim side. I don't know, Kendra, do you have anything to add about that? Or?
Yeah, so I think it was covered in an older version of this workshop when we talked a little bit more about MSIS and the production of the MAX data. And my understanding is that the Medicaid has requirements for what states should be doing in their own information systems. So that's how the states keeping track of information in their program. And that might be a source of information that then gets fed into the Transformed Medicaid Statistical Information System, but it's more focused on the actual management. Does that sound right, Steph? Do you have anything?
Yeah, that's right. And I think, so sometimes I think you might be able to get that type of data from a state, but it doesn't, it's it might feed into this, but we don't have a lot of information about that. So
yeah, Steph, I would back that up. I think sometimes researchers do get Medicaid data from their state Medicaid agency, and so the Medicaid agency may refer to the data as doing a data pull from MMIS or something like that. But yeah, I mean, that's the more the internal kind of processing for Medicaid. So yeah, so people might see that, for instance, if you do a data request to a state agency or something like that, they may use that term.
And then I think maybe something we might want to follow up with or talk about later is using TAF and MAX together. I think it is kind of unique that there are some years where you're using a combination, and if you're trying to track MAX and TAF with one state over time, that can be tricky. Do you have any good resources for using MAX and TAF together that you've encountered in your work?
I think we can follow up. I don't have anything offhand. I do know some of the challenges, you know, there are these different file structures. MAX didn't have some of the CHIP beneficiaries, so you're going to find quite a different set of variables. T-MSIS expanded the information collected quite a lot. And then also the eligibility categories with MAX, they had the MASBO. If you were working with MAX data, you might know more about that. That is not the primary reporting of eligibility in the T-MSIS. And so if you're trying to follow a particular group over time, there's some work that needs to be done. But yeah, we can definitely follow up with that.
And then we had quite a few questions about what types of services fall into which file type, but I think we answered them later in the study, so or in the presentation. So if you have any questions about that, please follow up. There are also questions about the records in the demographic and eligibility file. One of them was who gets included in each of the segments. Does everyone have a record? If they're not in managed care, are they in that managed care segment?
No, and luckily there are indicators on the base file, so you can see, does this person have a record in one of these supplemental files? There's, you know, one indicator for each file. So it's not necessarily the case that every person would be in every file.
Great. And then the demographic and eligibility file is comparable to the personal summary file. Someone asked that question in the MAX. So again, maybe we can follow up with some more MAX TAF resources. We had quite a few questions about identifiers and how identifiers get assigned. So what are the implications of using MSIS? What's going on with Benny IDs? Why are they missing in some states in some years?
Yeah, so the rate of missing is really low, but it's possible, I think it happens if, you know, so CCW in the final processing of TAF RIF, if there's not an MSIS ID, the claim will get dropped. But if there is an MSIS ID and yet it can't be assigned exactly, like there's not enough information to assign a Benny ID, you may find that the Benny ID is missing. The rate of missing is quite low. I don't have it off the top of my head, but it's 5% or less, I think. And it varies by state, which would be kind of the resounding thing that we're going to say this workshop. but no state is overwhelming in that.
Yeah, so I think another question maybe about beneficiary IDs is, will that be used for MAX and TAF? So the Benny ID is assigned by the data distributor, and it's encrypted by research project or data use agreement. So if you have MAX and TAF data under the same DUA and somebody is identified definitively in the MAX or TAF data and is assigned a Benny ID, that will be carried across the files for that project. And then there was a related question, because the actual identifiers are not included in the files, can you link the Medicaid data to individuals if you have their identifiers?
Yeah, so that's something else that can happen. You would have to work with the data distributor. So it's possible to send a finder file that would then be linked, and then you would get the data out from that.
Yeah, and that's only possible under a RIF, a research identifiable file DUA, but it is one of the features of the RIF data use agreements. You can link at the individual level to the CMS data. There's a question about the disabling condition indicators in the DE and the source of that information. Do you know, Steph?
I would have to look. It's submitted by the state. The state is collecting it in order to determine the qualification or eligibility for the, and actually, so I'm curious if it's SSI. I would have to double check though. So sorry, SSA, the Social Security Administration, who would also administer disability. So yeah, I would have to double check.
Yeah, it is eligibility. So I think it's not, if you're familiar with the Medicare data and the CCW's chronic conditions indicators, where they develop indicators from the claims, it's not a claims-based assignment or anything like that. It is pulled from the state's eligibility and what they're submitting. And then we had some questions about the managed care files and the managed care, the plan file and the provider file. These are pretty new. These are released first this summer in June for 2014 through 2016, and they've been added to other TAF with more recent releases. So if you're wondering, why don't I have access to this? It might be that the file is not on your data use agreement. It hasn't been included yet. The provider file does include NPI information. See?
Yeah.
Scrolling through. Question about how to look for continuous enrollment. I think we have a whole segment dedicated to enrollment and disenrollment later, so maybe we'll talk about that one later. When information's redacted, is it marked as redacted? Is it set to 0?
Right, so you would, I believe it's actually missing. But the way you would be able to identify that it was redacted on the basis of that it's a managed care claim would be using that claim type code indicator.
And then I saw one question that I might need to follow up on about linking information between the header and the claim line.
Yeah, so we have what you will see if you could put the two files side by side is that you would have one line per claim in the header file, and there's a claim ID, and then you will have possibly more than one line per claim in the line file with a claim ID. So you would be able to link the information, but yeah, it does become a little bit complicated depending on what you're trying to do.
And someone asked about separate insurance and whether or not that can be identified in the Medicaid data. So previously in the MACs, there was a specific private health insurance group code variable. Is there anything comparable in the TAF?
To be honest, I don't know. So that would be something I need to follow up on, but
that was
I can find it. I can have that off the top of my head.
Yeah. So managed care plan, how can you identify comprehensive versus other types of managed care?
Mm-hmm. Yeah, so you will, in that managed care file, you will be able to look at the plan type. And so you'll be able to group plans based on whether or not they are primarily for a specific condition or a specific service type, or if they are comprehensive. So we can talk a little bit more about that too later.
I'm just reading the new questions that came in. Stuff you can probably read them.
Oh, sure. Yeah, I could probably do that. Yeah, so the question is, are the eligibility and enrollment data complete? We are going to be talking about this a little bit in the data quality section. The completeness and the quality of the data will vary by state, and they have, CMS has put together what they call the DQ Atlas, which we'll talk about later. So you can look by state, and it does go by category. You know, how confident are we in their eligibility and enrollment information? So yeah, we can talk a little bit more about that, and it may result in claims, like you said, that have, like, the service date begins in the previous year. It could be that it's included on the basis of the end of the claim date. So that could be one reason why you might see that. So if you want to link Medicaid and Medicare data, the BeneID is actually universal for all the CMS programs. So that is one nice benefit of the BeneID. I don't know, Kendra, if you have anything to add with that.
I guess what I said before, the BeneID is an identifier unique to the data distributor CCW. It's encrypted by data use agreement. So by project, the BeneID will be universally assigned across all file types obtained under that DUA. So Max and TAF and Medicare.
And there's one question specific with the Illinois claim TAF guide. That's something that I would like to follow up on as well, in terms of, because you might see multiple iterations of a claim. Which one do you choose? We can certainly follow up on that later as well. And then for people with presumptive eligibility, would we see claims but no enrollment in a given month? You should have an enrollment record, would be what I think. But this is another one where I think I'd like to follow up. I say that just because there was the note from CCW that if they don't have an enrollment period, they do drop the claim. But with presumptive eligibility, I think you're going to see it. You're still going to see them being eligible. I guess you may see a claim. It may be before their service date. We'll have to follow up on that. And then if TAF files are not in the same DUA as our Medicare DUA, can we request a crosswalk file? So it would be, you'd have to probably do an amendment to request the TAF files. If, you know, you can request the TAF files and the BeneID. If it's on the same DUA, the BeneID will be encrypted with the same encryption. So you should be able to do that. Is that correct, Kendra, or am I missing anything?
Yeah, so if you're using any data for one study and any data for another, and you want to use one set for another, you need to have those specific files on that same data use agreement. So if you're using Medicare data and you want to add Medicaid data to that project, you'll need to add the Medicaid data to that data use agreement. And then we would also work on the details of obtaining the correct encryption identifier to make sure the data can be used together.
And then I think we're getting short on time, but for the amendment process, Kendra will be talking about kind of the whole request process in the final segment. So that will be tomorrow. And then the crosswalk is what would apply for a reuse file. If you want to reuse from a previous DUA, you would have to indicate that on your current DUA and then request a crosswalk.